My name's Phil Hartley, and I have the pleasure of being your host today. Welcome to our Health Disruption Symposium, part of our Digital Insights series. This is the fifth in that series, and really what we're looking at today is patient first by design. I'm also your warm-up guy, so as the warm-up guy, I have to do a joke apparently, so here's my only medical joke that's clean. I went to see the doctor the day, and I said, Doctor, I think I'm a billiard ball. He said, get into the queue. Thank you very much. So you should all have food and drink, I hope, that's done. And so before we get going, I'd like you to have a little think about a few things. As we talk, I'd like you to consider your own experience in our healthcare system, either as a user of it or as a provider to it. As we talk, think through those things there. Think about your emotions, think about your daily activities, etc. And the other thing is, if you wouldn't mind, is have a think about the disruptive technologies in your industry, if you're not in the health industry, and whether there are similarities and comparisons to what we're going to talk about today. So a little bit of a personal journey. I'm in my late 50s. I know it's quite surprising. And I'm probably fitter than my father was at the age of 40, in his late 40s, excuse me. Strangely, he's probably fitter than I am now, but that's another story. I sort of visit the doctor probably 4 to 5 times a year, which makes me a borderline hypochondriac, I believe. And I've been under the knife in my life 5 times. One of them was life-saving, which is possibly a bit of a problem for my 2 Gen Y children who need inheritance to buy property. And one of my children at birth was also had an operation to save his life. So the health system, for me, in my life, has been fantastic. It's paid me well. I'm a big user of it. But I'm fit, and I'm fortunate to live in an era and in a geography where we have a great health service. It's not available to everybody. And I think the other thing is that the technology in health has moved at an amazing speed. So I don't know if you guys, anyone's the same age as me here, but remembers Dr. Barnard, who did the first heart transplant in December 1967. That was the first human-to-human transplant. So if you then cast forward now to where we are, which is almost 50 years later, well, it's more than 50 years, we've now got mini intestines being grown in Petri dishes. We have the ability to do microsurgery, super microsurgery, with robots. And we've also sequenced the gene, which is amazing, because the power of that technology is incredible. But the thing we're going to talk about today is we're going to talk about how IT technology is now the next part of that evolution. So, before we go any further, I think we'll just get straight to it. So today we're going to have 2 speakers, and we're going to have a little demonstration as well, because we want to try and explain and show how a new health model can be applied. Rallis Buttress will speak first, a little bit about his own personal journey in health, and then Dr. Edmund Tsay will also speak as well, and Edmund will talk a little bit around the Healthy Link application that he has built with his company, Guess It, with ourselves. Rallis is a renowned leader in technology. I had to read this out, I'm afraid, because it's quite long. He leads DB Results health technology practice and sought out by our partners to implement innovative and cutting-edge digital solutions. Rallis is one of the defining architects of the National Electronic Health Technology Architecture and worked for 13 years in the Department of Human Services focused on the health industry. He has the brain the size of a planet, to be honest. And Dr. Eddie C. is the senior hepatologist and liver transplant physician at the Royal Adelaide Hospital. He's also completed his Doctor of Philosophy in hepatitis C and has worked at the Royal Darwin Hospital as a visiting specialist since 2009. He is the primary hepatology specialist for the South Australian Prison Network for management of hepatitis C infection. So I think we might be talking about hepatitis C today as well. Okay, Dr. Phil and Dr. Google are in the house as well if you need any help. So Rallis, would you care to come and join us and kick this baby off? Thanks, Rallis.
Thank you. My clicker. Thank you. So, thanks for the introduction, Phil, and I'm glad you had to read it out because I don't know when you wrote that, But as obviously I didn't have a hand in it because there were a few things in there that I would have corrected you on. So before we start, and coming back to Phil's point about recalling your latest significant interaction with the health system, either as a provider or as a consumer. So we're not talking about regular visits to the doctor to get a script, pulled shoulder, tennis elbow. I'm talking about a significant one that involved yourself, maybe someone from your immediate family, GP, hospitalisation, pathology, the gamut of health services. So just call that to mind and put yourself back into the situation you were in when you were encountering the health system within that context. So just take a moment, because it's really important to actually feel that again. So the question I have was the feeling that you were getting that you were being incorporated into that solution. Was it being done with you, or was it being done to you? Were you being treated as a patient, or were you asymptomatic and you're getting symptoms treated? Someone was attacking your disease or attacking your ailment. Were you being included into that? Were you being informed? Were you given permission? What was the consent ratio? When the forms you were signed, did you read them all? Can you recall them? How many you signed? What you did? How it made you feel? That's the health system that we work with today. So to understand that, I'm going to take you back a little bit. About 4,000 years. It's going to be quick. It's a brief history of medicine as a brief history of time. Originally, when you suffered an ailment, you were ill, you went to see your local physician, your shaman, your churgeon, and they treated you as a whole person. They knew you had a longitudinal relationship with them. They're probably the same person that was in the village or in the hamlet that we were with. They didn't move, you didn't move. It was all local. They knew you, they knew your family, they knew your history. And they did a reasonably good job of beginning to diagnose your problems. They knew what you had before, they knew what they had to treat, what your history was. It came through. Over the centuries that intervened, we got really good at diagnosis. We got better and better. We developed tools, facilities, aids. We got really, really good at being able to identify what it is that you had and therefore what it is I need to do to treat you. Attended with that, the technology. We went from scraping off the lining inside willow trees to get the active ingredient. We started to develop the concentrated active ingredient. We got aspirin. We got better and better in the technology. We applied it. We learnt. We applied the scientific method. Then we moved into a stage of curative medicine. So we still had diagnosis going on. It was still being developed, still being refined. But what we were now doing was we were curing the disease. We were looking at the symptoms, we were applying it, we were looking at the root cause, we're saying, yep, that's what it is, that's what has been exhibited, but this is what we need to cure. We're curing that disease. We got better and better and better at that. More technology, greater awareness. And with that, we started to bifurcate medicine a little bit. So you weren't just a general shaman or a general herbalist or a physician. You now started to specialise into one area. So you went to see someone when you actually had a stomach upset, when you had boils. There were certain people that went to that actually had an affinity for that particular type of ailment. Over the centuries, we got better and better at that curative stage. We then moved into, well, how do we stop people actually becoming sick to start with? There's got to be something there that's actually causing it. We started to look at what were the vectors of delivery, what were the actual organisms that caused the diseases. And we wanted to stop them in their tracks. So coming back, Edward Jenner, we started looking at the very first vaccinations. And that wasn't a case of curing you of something that you had, it was a case of stopping you from getting it in the first place. So it's a reasonably confronting image up there, a young child with smallpox. Thank you, Eddie, for that one. The last case of smallpox confirmed 1977. World Health Organization wanted to actually declare it eradicated in 1978. They finally did in 1980. So with the application of the diagnostic knowledge, the curative facilities we had in place, the application of technology, we got to the point where the first time in human history, we had the facility to prevent an active disease from affecting our population. Over the intervening decades now, we've gotten better and better at actually what we need to do for the diagnosis, for the curative, and now for the prevention of those diseases. And Ed will be talking about what we believe that is possible within this country to tackle the eradication of another disease. But we're on the cusp right now of moving into a next phase of medicine, which is restorative medicine. And we're not giving up on diagnosis, we're not giving up on curative medicine, we're certainly not giving up on preventative medicine, but we're now moving into what do we do when we actually have something that we can't prevent and we can't cure. So to take Phil's point, personal journey, I have an incurable, non-preventable condition. There's nothing they can do about it except monitor it and make sure that if I do have a flare-up and another episode, that they catch it early. It's genetic, it can't be fixed, yet. In restorative medicine, we've got the ability and the facilities available to actually map the genome, find out what's going on with it, look at a possible repair. So I can't get back what I've lost, but I can repair what's coming, so I have a better future. So any Star Trek fans in the audience, remember one of the lines that came out of one of the early movies that we don't really talk about because it wasn't a good one. The doctor gave me a pill and I grew a new kidney. So the graphic up there at the moment is a bionic kidney. Not yet in full use, it's in trials, etc. But if you think back at the things that we've done to augment human health by the application of technology, it shouldn't come as any surprise that we're on the cusp of something big, and IT is actually going to facilitate some of that. So Eddie's certainly going to be talking about and demonstrating some of that capability in the future. So it is a journey. It's not a step thing. It actually happens in transition. But as one of the outcomes of that transition is that when we started, we had a single person that provided holistic healthcare to us. At the end, we've got, quote unquote, an industry. We have specialisation to an amazing degree. Nuclear medicine, a new field that didn't exist 50 years ago, now commonplace. We have PET scans using what is essentially atomic particles to work out what our cells and our internal organs look like. It was unheard of. That is Star Trek technology. And yet it's just crept up on us. No one's really said, oh, that's phenomenal. The general population, they know about a scan, a CAT scan, an MRI, PET scan, but it's just a machine that takes a picture. They don't recognise the technology and the research and the effort that's gone in behind it. So we've got a medical industry at the moment which is incredibly specialised, incredibly technical. There's lots of people doing things for us, but an outcome of that is fragmentation. The number of people you have to talk to, the hydra of health. How many heads do you have to talk to in a complicated medical situation? So coming back to that significant medical and event in your own life, how many heads did you have to talk to? How many heads talked at you? So we've come a long way, but in some cases we've gone backwards. It's more difficult now to actually understand what holistic health looks like, what collaborative health looks like. What do we do? That's the problem. The health system, as Phil said, is really good. Acute health is great. We intervene, we diagnose, we cure, we try to prevent anything that outcomes that are not warranted at the end of that, and hopefully in the future we're going to be into restorative practices. Acute health is fine. Chronic health is a different kettle of fish. So hopefully for the medicos and the doctors in the audience, I'm not going to be telling you things that you don't know, but maybe with the research we've done, will be. 1 in 2 Australians suffer from a chronic health condition, which means if it's not you, the person sitting next to you at the table today is probably sitting there thinking to himself, oh, he's me. And there's a couple of people patting a few people on the back, so they obviously know. So that's an astonishing figure, 1 in 2. That means 10 million Australians, on average, is suffering from a chronic condition. If we could save $100 per person, which is usually much less than the gap that you pay for a decent pathology test or imaging test, $100, we would save $1 billion out of the health budget tomorrow. 17% of pathology tests are either repeats or duplicates. 17%. You don't need to bump that too much. You're talking about 1 in 5 tests. That's a phenomenal amount of money you could save. And what did we do? We didn't do much at all. We had a very small change in the efficiency of the system. Now, I had an example of that 3 weeks ago. My wife went along to the GP, said, yep, okay, I understand what you want to do. Yep, off you go, blood test. Here you go, Melbourne pathology, done. She also needed to see a specialist. Phenomenally, she got in to see the specialist on the Wednesday following. What's the first thing the specialist did? Oh, Dorevitch pathology, I want to have a blood test. I looked at the 2 forms and went, they're identical. They are exactly the same test because it's the same condition she's been treated for. So it's funny enough, they're looking for the same thing. So I said, you don't need to have 2 blood tests. You can have 1 blood test and just get the results sent to both doctors. She said, how do you do that? I said, well, you have to take both forms along to one of your selected pathology. The pathology nurse, I won't tell you exactly what she said to my wife about the 2 pathology requests, but said, yeah, all you need to do is authorise that your results for one of these doctors can be sent to the other. You can only have just 1 test, done. And I said, so how many people get those 2 forms and go along and have the test at Dorevitch because it's a Dorevitch form, and go and have the test at Melbourne Pathology because it's a Melbourne Pathology form. For exactly the same test. Each of those results go back to each of the requesting doctors, and they look at those results. If that person isn't an active participant in my health record, it's the Hydra has started. You're talking at multiple heads. There's got to be an easier, simpler technology way of making that sort of problem go away. The whole point is to get people back to good health. Now, there's a jaundiced view. Some of the medicos in the medical profession don't do it because they're doing it for a vocation. They're doing it because it's a really good job. I suspect that's an incredibly small number of people. Everyone that I've met in the health profession definitely had my best interest at heart. It's just that their best interest is unary. It's one-on-one. It's not the collaboration that we need in order to make this entire thing work. And it can become frustrating, disenfranchising. How many times do I have to tell you people the same story again and again? So there's got to be a better way. That erodes trust. If you've got to tell a group of people that supposedly have your best interest at heart, they're trying to treat you the same story again and again and again, it just erodes trust. Doubt creeps in and it has a cascading effect. Collaboration and trust are the 2 things that we actually want to reinvigorate and reinstitute back into it, so you're back to talking to the same person in your village that knows you, that knows your history, knows your family, knows what drives you and can get you back to full health. We're working with some really great people. NDIA. That's a case of it's not what you know, it's who you know. The new CIO there is someone that we've worked with in the past. He was looking at putting in a health strategy to get them back on track, what they needed to do. He said, there's only one group I want to talk to. And I think he called Gavin. Where's Gavin? And said, do you guys have people available who can assist? We do, so we're up there working with them now. RMIT, Alistair's here. Jason is not. We're working with the Blockchain Innovation Hub there on looking at a technical way to reintroduce trust. My health record, really low adoption rate. Why? You ask people, I think the forum, the Consumers Health Forum actually asked people that question, and the single largest reason why people don't want to use it is they do not trust who's going to use the data. So we need to reintroduce and reinvigorate the trust aspect into the health. Pardon? Why? Okay. How many people here, first of all, know that they have a My Health record? How many people here have actually looked at their My Health record? Okay, and this is the kicker. How many people have had to correct their My Health record? Yeah, there are some well-documented cases of people having to correct primary data on their My Health record and also allocated prescription information that was added on, and they go, I never got those drugs, I don't know. Which in their case was just antibiotics, but if it had been something like warfarin, you know, and you look at, and someone did an emergency check on your My Health record, see that you've actually got a blood thinning agent, well, you must make sure that you get that right. Again, trust, accuracy, collaboration. The Australian Prostate Cancer Research Council, we're working with them to take their very useful platform they've got at the moment, which invites those individuals who are suffering from the disease, their family and the supporters, actually adds in all of the support around that so they can go to services, they've got access to new information on the treatment of the disease or the cancer. Recently, I think the PBS actually had the new drug allocated to it for the treatment of long-term prostate cancer sufferers, which again, like the drugs I think that Eddie's going to talk about, reduces the cost for an individual basis dramatically. And Health eLink, Eddie, who will be talking about that, will actually demonstrate, he will demonstrate what we've actually done in order to facilitate an increase in collaboration and a reinstitution of trust. So the future. So calling back to mind that interaction that you had with the health industry services at the beginning. Now imagine that all of the things that you negatively thought about were gone. Would an increase in collaboration and trust, an accuracy of medical records and the reduction in the number of people you actually have to talk to, how many of those negative emotions that you felt would be removed? It's a simple thing, but it's an incredibly powerful thing to know that you're actually a member of a team who is working with you rather than the target of a team that's doing it to you. And with that, I will hand over to Eddie.
Thanks, Rob.
Who will walk us through Health eLink.
Yeah, thanks, Ralis, for the excellent starts to the presentation. Thank you, Gavin and Andrew, for inviting me this morning to speak to everybody about the Health eLink initiative. It's actually a bit strange for me because I've never had to present to a different audience such as yourself. Normally, I present to my colleagues and specialists, and it's very data-driven, but I think this morning it was going to be a different take to what Health eLink is about and really describe to you about the journey that we have come in the last 12 months. So I'm a gastroenterologist with a special interest in liver disease, and in the last 10 years of my career, I've more or less been a public specialist at the Royal Hospital at that point in time. So I know a little bit about the inefficiency with the public system and how patients that need to come and see us don't really have access to see us because of lack of resources and so forth. Furthermore, I go up to Darwin once a month, and I've been going up there since last 10 years, and that was what I call my PhD gig. During the time when I was doing my PhD, I was on a student stipend, and got to feed the family and feed yourself, and that's where I went. And Darwin is a very unique place where, unfortunately, not dissimilar to many areas of Australia, that geographic distribution of our patient makes it really difficult for patients to engage with us. Even with the advent of telehealth medicines, it's a very artificial environment where you're seeing the patient through the telehealth system for 20 minutes at a time. You still not only have to deal with the patient, but also the GP at the same time, because the GP, even though they're excellent in terms of what they do, they sometimes lack the skills of a specialist. for which they only need a bit of coaching and a bit of guidance that if you provide to them, not necessarily only within the half an hour time frame, they can actually manage a specialist condition no different to what I can do. Because what I've learned in the last 10 years is that probably 80 to 90% of the patient I see in clinic, actually their condition is fairly stable. I'm not always changing medications, I'm not, playing around with diagnostic scans and so forth. A lot of our patients actually have very stable diseases. It's only about the 10% of those patients that sometimes can't get access to us because of the fact that they're actually sick and they're not in a review appointment because I'm supposed to see them at 3 months or 6 months or 12 months. But also, if they are sick, they can't get in to see a GP. So upskilling the GP in terms of patients' conditions, at least to a level where they can monitor for flares, is very critical. And that's where Healthy Link comes in terms of how we want to disrupt medical care to make it more efficient and make it much more access to everybody, particularly those people who can't get access to specialists. So we're going to talk a little bit about chronic diseases and as well as hepatitis C infection, which has been a fantastic innovation in the last 12, 18 months, especially how Healthy Link has helped to deliver that care, about the major benefits and features that we have within our system. So Raul talked a little bit about this. Chronic disease is a major problem, and it affects 1 in 2 Australians. And we know that a quarter of Australians actually have 2 or more conditions. Now, we live in a very fortunate society where we have universal healthcare, but universal healthcare, unfortunately, comes with great expenditure. And there is, unfortunately, a limit to every spending, and we are spending a huge amount of money, $170 billion in terms of money on an annual basis. And I was looking at this data just in liver disease. Liver disease alone is about 500 million. So in order for us to really preserve our very fortunate healthcare system, we have to have some accountability. We have to ensure that our spending is appropriate, and we also have to make sure that where things could be streamlined and access, we're doing that as much as we can. Certainly, we do know that hospitalisation is very preventable. About 40% of hospitalisation is preventable, and it largely comes around in situations, for example, when a patient with a chronic condition that becomes unstabilised, they see their GP, and the GP goes, well, I think you're sick. I don't know what to do. The easiest way to get into a specialist is to go to the emergency department. And because of the lack of access to us, certainly as a factor, it plays a big role in terms of unnecessary admissions as well. And we know we can do better with chronic diseases. We can certainly be preventing more deaths, and up to 7 out of 10 deaths are because of chronic diseases alone. So in terms of hepatitis C, you've heard a little bit about that this morning. The reason why we are talking about hepatitis C infection is that, not dissimilar to smallpox, which has been eradicated 3-4 decades ago, hepatitis C is now on the precipice of being potentially eliminated from our society. We're looking at an elimination strategy by the WHO aiming to eliminate hepatitis C by the year 2030. Now, Australia is the only country in the world where we have these potentially very expensive medications, up to about $80,000 per treatment course, to help facilitate elimination of hepatitis C by 2030. Now, it's a huge investment, but the Turnbull government has put in $1.2 billion to this in 2016, because even though it is a significant investment initially, we do know that as a result of increased uptake in eradication of this condition, we'll end up saving money in the long run. Now, the numbers are very clear that provided that we can get as many people treated, we can then have savings subsequently, just in dollar value, not talking about quality of life, any of these other things that we value as a doctor. The problem is, we know as a specialist now that treatment initiation is dwindling. Now, you might wonder, well, you got this tablet that is quick, simple, no side effects, why wouldn't people take it? And that's a very good question. Now, there's lots of barriers to delivering care to people, and even though smallpox had a very effective vaccine. It wasn't just the discovery of this medication that led to eradication of this condition. It was a systemic delivery of this medication through the WHO to people of need, which allowed that to happen. Now with hepatitis C, we have invested $1.2 billion in this, but we don't have a model of care to deliver these medication out into the patient in the community. So for example, you've got your mums and dad's GP and you see maybe 3 or 4 Hep C cases a year, and you really don't know much about this condition. You know, prior to 2016, every Hep C I was sent to Eddie, no questions asked. Dr. Eddie, please see this person with Hep C. See you later. Now, we're telling the GPs in a complete 180 that this is a GP-related thing, no different to Helicobacter. I'm sure you guys have heard about Helicobacter. No different to Helicobacter. You just prescribe these medications, no different to antibiotics. Away you go. There is no side effects, no real problems, but there are caveats that if you have these medications that has significant drug-drug interactions, you could make the patient really sick, or hepatitis C, as you know, can cause cirrhosis. But if you miss cirrhosis, you're going to be doing your patient a disfavor. And then when you tell the GP this, they go, oh, well, this actually is not as simple what it is, which makes it then very difficult for the GP to confidently prescribe these medications to ensure their patient in front of them can be cured. A lot of those patients, for whatever reason, don't want to come and sit in the waiting room to see me. And because of activities they've done 40 years ago, one time they experimented with drugs, now they're a high-flying professional, they don't want to be seen in a infectious disease clinic patient in a public hospital, seeing a strange doctor for the first time talking about hepatitis C. So you've got your GP that have known him forever. They will say, Dr. GP, I'd like you to treat my hep C. But unfortunately, they don't feel confident to do that, right? And then you've got your patients up in the Netherlands, in the country where you actually have no real access to specialists. Again, where the GP knows very little about this condition, how do you empower those people to take up this medication that allows them to cure this condition, as well as to allow us our goal of elimination until 2030? That is our challenge at the moment. To the level that I'm working on this with a PhD student of mine who is a gastroenterologist, James Herity, that we're looking into barriers to eliminate these conditions. And now hepatitis C is just one example. It's no different to any other conditions where a GP dealing with ischemic heart disease or diabetes or so forth, if you have a heart condition and you go and see a specialist and the specialist asks you, well, how's your exercise tolerance, how's your breathing, how's everything, all good, no worries, see you later. Why can't that be done remotely? You know, why do you have to take half a day of work to park your car somewhere, rush to see a specialist appointment, only to find that he's running behind for half an hour, and a specialist then tell you, oh, you're doing well because of a few questions he's asked you, and review blood tests that he could have done remotely. So these are slots that potentially could be utilized for people that actually need to see a specialist in real time because they have a destabilized condition or a new referral that need to be seen. So we talked a bit about patient-centered design today, and that is something that is a bit of a buzzword that's been bantering around, and I do believe in this, and it is a critical problem. Because just to take hepatitis C as an example, most of us know as specialists that our patient retain maybe 20% of our consultation in terms of what they are told. And in particular, hepatitis C is the algorithm, the treatment plan for taking the medication can be a bit confusing because you get given a script which has 2 repeats, and each script lasts a month. So I'll tell the patient, so you take the script to the chemist, you'll get 20 to 8 days worth, but you've got 2 more repeat on the script. By the time you finish, you need to have a blood test 6 months after the date you finish. That, in my mind, is fairly straightforward, but for someone who is not medically oriented, they just don't get that information and don't get that gel in their head. So to be able to provide a treatment plan that not only for this one condition, but maybe they have other conditions as well on top of that, and how they all relate to each other is critical. Just as Rallis was talking about, inefficiency with blood tests and things are extraordinary. Now, Rallis pointed out in that situation where they actually got 2 forms in their hand, But most of the time is actually not 2 forms in their hand, but 1 form they done a month ago to see the GP, and one form a month later, which they're coming to see me. And in that setting, patients will think, oh, they're probably 2 different tests. But in my mind, a month ago is really no different. It's a chronic illness. A blood test a month ago is no different than a blood test yesterday. So in that setting, if we could seamlessly amalgamate people's condition in terms of the investigation and blood tests together to deal with the patient as a whole, rather than me being tunnel visioned in terms of managing their liver disease as such, will help obviously be more patient-centric, allow them to be empowered, as well as involve other healthcare professionals as well. One aspect that we haven't touched on today is also engaging this GP as well as the specialist, have them centered equally as much as the patient. Because if I can't win over the GP to manage this patient in the community, they will just write a referral and send them back to me. So it's really important for me to get into the mindset of the GP to make sure that they feel comfortable dealing with this patient with me monitoring the patient remotely, to make them feel just as confident dealing with the patient themselves as if they were sending it to me. So more than patient-centered, our design has been healthcare-centered of all the stakeholders, not just the GP, not just the patient, the GP, but also to the specialist as well. I need to convince my colleagues to say, it's okay to relinquish your control. It's okay to send your patient back to the GP. It's okay to be safe and be effective and open up your clinics to allow for people to come in. So that's where the challenges were with Healthy Link. And this is just the beginning. So the platform that you see this morning is a bit Hep C-centric because we saw an opportunity in terms of proving a point. But our platform has been designed specifically to target any chronic diseases. You'll see this morning, Healthy Link is really a tool, but what we are really advocating is a new model of care, is a new way of designing the healthcare system. Just like how we talked about this, Uber disrupted the taxi industry, is a new way of you getting from A to B. So Healthy Link that you see this morning is like the app within that system. It's a new way of thinking healthcare. So unless people are confident in getting into a stranger's car and have them take you from A to B, even the best app out there that can do everything won't do that for you. And that's what we're trying to do, to allow for people to be confident in terms of our model of care, to be seen by the GP, but as if you were being seen by a specialist, and in real time you can get back into the specialist care if and when you need to. So new models of care is needed, and the reason for that is for lots of reasons. Firstly, this is more of a conventional healthcare that you'll know from day to day, where for patients, say this lovely lady here, at any one time could be seeing 3 different specialists, and for 3 different conditions. And typically what happens is that we will send a letter from specialist A to B to C and back to the GP. And a lot of times the correspondence takes time to actually get there. Now, one scenario I know very well is there's a specialist in a local hospital near us who is a cardiologist, and he's been started a patient on warfarin and told the GP, hey, by the way, I'm starting a patient on warfarin, can you please monitor it? That letter didn't get to the GP for a month. And as a result of that, the patient was taking warfarin, and the INR, which is how thin the blood is, gone up and up and up, and actually had an intracranial bleed. And that looked really bad from the specialist's point of view in terms of the coroner's inquest, because of the fact that, we have such bad communication with our colleagues, and it's very much one way. And if I had to write something to the GP to say, hey, please do this person with, do this to my patient with hepatitis C, and they don't really quite get it, it's really hard for them to get back in touch with me. They would ring me and leave a message on my phone, and by the time I ring them, their secretary said, oh, Dr. So-and-so is in with a patient, can we take a message? It's impossible to get in touch with each other. It's not really dynamic. So the model of care, from a doctor's point of view, has been really entrenched, and we haven't really moved with technology. Certainly in liver transplantation, liver disease is a sub-specialization of gastroenterology, which is the bigger discipline. So when you have specialists within specialists within specialists, you will actually get more disenfranchised as a GP because you actually just get so confused about what advances are out there. How can I keep up with everything? How can I be up to date with all that's out there? So they feel in a way that is simpler just to refer the patient to the hospital for management. Now, with better diagnostic tools nowadays, most patients who come into my door, by the time they get there, would have had an ultrasound or CT scan a week before they see me. Now, if that's the case, do I really need to do an abdominal examination? Are my hands more diagnostic than a CT scan? But sometimes there's an expectation from patient to say, oh, are you going to examine me? And I was looking at their scan just now with them. Well, do you really think that my hands are going to be better than the CT scan? But that's an expectation that patient has. So it's to address this expectation to make sure that they feel comfortable that you're doing a good job to the level that they are happy to be managed in a way not necessarily with a face-to-face encounter, and they feel benefit from a non-face-to-face encounter are critical. So I alluded to a little bit earlier, diseases are unpredictable. They don't flare at predictable 3, 6, 12-month timing where you go and see a specialist. By the time you have a flare, how do you re-engage a specialist? Do I ring a hospital, which is commonly the place where you see the patient? Will you be put through the right person? Will you be then booked into a clinic appointment that will allow you access to see them easily? So all of these things are challenges for patients, and as I said, they then go and see a GP which may not know about their conditions very well or how to manage it, and that is a bit of a problem. Now, everyone in this room has a mobile phone, but commonly people are not talking on the phone anymore, but they're actually doing messaging, WhatsApp, iMessages much more commonly than ringing on the phone. And using that, I think a lot of our patients, especially younger generation, will be quite happy to engage professionals in that level if they can get access on demand to a specialist or a specialist nurse in that scenario. So if I was able to message them and say, look, your blood tests look great, or your scan that you had just recently down the road near your house is great, don't worry about coming into hospital, we'll do it all again in 6 months. Let me send you these scripts and scans digitally and get them done again in 6 months, and we'll go from there. And they'll be quite happy. They don't have to miss a day of school, or they don't have to miss a day of work, and everybody's happy, and the patient don't actually have to be physically in my consultation room, which, again, increase our waiting list. So what we propose is a digital solution which is in real time, but develop virtual links, where a patient directly sees a GP face-to-face, but the GP also has access, along with the patient digitally, to the specialist to allow for everybody to be in the loop about management of the condition. So it's not so much about palming the patient back to the GP, never to come back to see the specialist. It's about building these links to actually monitor the patient when they become destabilized, to then get them back to the clinic of a specialist as required. But if they're stable and everything's going well, and I tell the GP, manage a liver test, manage the viral load, and if all of those are normal, don't need to send them back for the moment, but if they do, send them back straight away. So HealthyLink includes secure messaging, and this messaging is more complicated than the encrypted WhatsApp threads that you have. So the messages allow for the patient to know exactly who their treating teams are. So just like when you have an address book, when a patient is engaged in HealthyLink, when they send a message, they'll only see about 3 or 4 names on that list. And these 3 or 4 names are the people that are actively involved with this patient care. So they know these people by name. And only those 3 or 4 people will have access to this patient's information. My login at the Royal Lake Hospital allows me to see everybody's health records that come through the door, irrespective of whether I've seen them or not. That's my access. But this allows us to give the power back to the patient by way of security, because if the patient is actually not involved with anybody else's care, why should they have access to their information? And similarly, if they need to speak to someone, they want to be able to speak to them that knows about their condition, which is why those pre-populated address book will be only people that they know and have relations with. Algorithm and templates have been built by specialists for that condition. So for me, for hepatitis C, these are the information that I need. So when a patient sees a GP, they can enter those information even with very little understanding of the condition. With the algorithm already built in, the GP are provided national-driven guidelines to the best of our abilities in management of that condition. There'll be simple treatment plans, which is very dynamic, and to really show you how that works, I think in a minute we'll do the demo. And the best thing is a very secure database that allows me to obviously know how many people have this condition, where they're at with their therapy, that significantly generate potential research and guideline-driven outcomes. So Catherine's going to help me today do a demo of HealthyLink. So Catherine will be firstly logging on to the GP portal. So HealthyLink, first of all, is a web-based platform. So we made a web-based platform to really allow for anyone and everyone with a web browser to access. So away you go, essentially, if you've got internet access. And there are 4 portals which will show you most, if not all, this morning. We have 4 portals because these 4 roles are all require different elements and different features. The first portal is the GP portal, and then we'll show you the specialist portal in a minute, the patient portal, and then the nursing portal. So firstly, Catherine is just going through what the GP portal looked like, and we pre-populated a patient by the name of Bobby Brown. And on this screen, you can see that at the moment on Bobby Brown's screen, Bobby is attached to a demo GP on the top left-hand corner. I just borrow that. And we've got some medication that Bobby has. So we picked 2 of the most common medication that's been prescribed on PBS. Atorvastatin, which is a cholesterol tablet that everybody should be taking after breakfast this morning. And pantoprazole as well. If you finish your breakfast, you'll probably need that for reflux, for pantoprazole. Thereafter, we will add a diagnosis. So Catherine is just adding that. So imagine Catherine, again, as a GP that really has very little interaction with hepatitis C in the past. So she's adding that at the moment. So this is the date of diagnosis, which is the 30th of May. And what Catherine's doing now is sending the referral to a specialist. And because Catherine's my friend, she's going to pick me as the referring specialist. Intercurrent conditions are conditions which are important in terms of deciding whether prescribing hepatitis C medication is safe. So she's just going through some of that for the moment. And a lot of these information that we're collecting is, again, going back into a registry that will give us more information about hepatitis C management for the future. This is where we are reviewing the medication list now, atorvastatin and pantoprazole. Yep, and currently we are linked to a SNOMED database for which really every medication that is being available on for prescribing within Australia will be available to be shown here. So it's a very lengthy list. So here, the hepatitis C history really relates to around when the treatment was ever dispensed in the past, what risk factors they have. The genotype is the strain of the virus, and whether they previously have had therapy before. APRI, it's an acronym for a platelet ratio, for which it really determines whether patient has got advanced liver disease. And one of the concerns that GP has is, am I missing really advanced liver disease that require treatment? You'll see that there's a bit of a green tick here that really indicates to the GP that the patient is non-cirrhotic, which means they're safe to prescribe without the need for specialists. So at this point in time, the platform is reminding the GP that this is a non-cirrhotic patient, you're good to go. And what you're seeing here in terms of the treatment choices, these are treatment choices as recommended by the Australian Liver Association. So based on the data that's entered by Catherine, she's already been told to the best of Australian guidelines what she's been prescribing. And really, it does not require any pre-existing knowledge on Catherine's part. Provided she's entered every required field, she will get to this point in terms of what to prescribe. So any of these treatment options will be sufficient in terms of eradicating the patient's hepatitis C in front of her. The only thing is these color codings will talk about the drug-drug interactions. So we are directly fed into the Liverpool University in the United Kingdom. This is a world-renowned repository of information of drug-drug interactions. Drug-drug interactions usually take years to accumulate because of experiences people have and feeding back to the Adverse Drug Committee. The benefit of the Liverpool University is that these are well-renowned clinical pharmacologists where they theorize whether there's potential interactions. So even though these drugs are very new, they could theorize there's likely interaction with these medication, and that allows us to prescribe safely. So what is red is an absolute no-no. What's amber is a possible interaction. And based on can we just click on the view interaction again table? So based on the view interaction table, the GP can now accurately prescribe safely based on where there's no interaction expected to possible interaction, and allow them to be much more informed in terms of what treatment choices will be best for the patient in front of them. Thanks, Catherine. So at that point in time, they select a treatment choice, of which at that point in time, they get given a treatment plan of what it might be, of what even Catherine should be doing, day -1 before treatment. And that's what Catherine should be doing, ringing our friends in Canberra at 1-800 888 333 for authority. So even if she never had rung up for a script before, she can follow this step to make a Hep C request. And then thereafter, if she's happy with that, or if she's not happy with that, she can then add a new treatment task. And that could be something related to she wants to do another repeat of a script because she wants to increase the treatment duration and put in a date that's due, and then amend the plan as she sees fit, and assign the task to Bobby, which is the person that is responsible to that particular task. And that's critical because these tasks are designed to be appointed to a certain individual. So as the task becomes close to being due, the person responsible actually be sent a reminder. So if it's the patient, they'll be sent a reminder by way of email or SMS and say, hey, you're actually due for this task. And they'll actually be reminded to make sure the task is going to be active. Now you see some of these, so the title here and the notes here is for Catherine to send me a note specifically related to this patient if she wants to. So she's going to put in something specifically to me to review. And then save the note. And there is it there. And then if she's happy with it, she's going to click submit and send it to me. Yep, so she's happy with that. She's requesting a specialist approval, and she's also requesting the patient to be seen in my liver clinic, and now she's sending it off. So that's complete. So now I'm going to log on with my login. So here is my login. You can see my name up there, and automatically you can see that Bobby Brown has come up on my list there. So I can click on Bobby Brown and review his medication choice, medications at the moment. And you can see that already Bobby has now got some other people involved with his care plan, including Anton, who's my nurse at the Royal Hospital, along with Catherine, who's a demo GP, and the demo nurse who is also involved with supporting Catherine, and then me as a specialist. So the patient will be able to see that these are the people currently involved with his or her management. So clicking on the diagnosis, we can then work out, looking at this template from what Catherine sent through, that everything is straightforward, that everything looks good, and there's really nothing of note that is particularly worrying. So based on Catherine's choice, she has picked Savosavir and Ladipizil for 8 weeks, which is an excellent choice. And then she's also mentioned place review task at day 100. So I'm going to write treatment choice. Looks great. So, and based on that, we'll approve the plan and send it back off to Catherine. So all of that was done potentially in a matter of minutes. Just to give you a bit of an anecdote, while Catherine logs on to another portal, we recently had an audit within our department at the Department of Gastroenterology at the Royal Hospital because of the paper-based system that we have, which is entrenched in the medical world. We estimated with our audit that up to about 20% of our patients currently are lost within our system. That's 1 in 5. So a patient potentially waiting for a procedure aren't actually waiting for anything because of the fact that their little bit of paper has not made it to the next person. So seemingly a very, digital referral system appears very simple, but just the mere fact of this can potentially improve our efficiency dramatically. Now, what you see here is a Google mailbox that, as a result of me approving the plan, this is the patient's Google inbox to say that the Healthy Link platform has sent them their treatment plan has been approved. So a patient have gone to see their GP, and the GP may have said to them, look, I'm going to send you this referral to the specialist. And a day later, they would have got this in an email and say, the treatment plan has been approved by a specialist. And then they can actually start on therapy. So what they see here is their treatment plan. So they will know that what they're supposed to do on day 0, day 21, day 28, what to do. Now that seems a bit arbitrary. So what Catherine's going to do is, today I'm going to take my medication. And as a result of her taking the medication on the first day, what you'll see at that point in time is that, you probably have to refresh it, Catherine. So what you'll see at that time is that all those days, in terms of 28 and 100, will become dates. So what that will allow us to do is for the patient to become a bit more aware of when things are due. And as she ticks off that she's done a task, you'll see that little green arrow comes up. And what's novel about this treatment plan is that as she ticks off this task, my platform or my portal gets updated as well. So that means that my patients are following my treatment plan, and that gives me instant feedback of how the patients are going. Just to give you a bit of an idea, the Royal Hospital treated about 800 patients of hepatitis C in a year, for which my nurse in the past, before these new medication came along, only treated about 100. So one person's job went from 100 to 800, more or less over a space of 12 months. Now, rather than dealing with everybody, we could deal with the exception, the people that don't have access to this. So if we can even have 20 or 30% of people clicking as they go along that they've done certain things, it will make my job and my nurse's job so much easier because I know that they're doing the right thing. I know that they're actually following their plan effectively. Yep. And then at this point in time, we can send a message. And these are 2 messages on the system to allow for the patient to know who their nurses are and write to them as well. And then finally, Catherine will log in as a nurse. So the nurses are the people that are the heart and soul of any chronic diseases. They keep everybody in track, not only the patient, but as well as doctors. They remind the doctors, you need to do X, Y, and Z for your patients. So their portal has been designed to more or less be the shepherd of everybody, to make sure all the patients are in line, doing the right things. And they also man a lot of the questions as well. Patients are much more commonly happy to engage a nurse as opposed to a specialist. They feel a nurse is much more approachable. So they may write to a nurse and say, oh, look, I've got a bit of a rash. And for which this is a picture of what they've taken. And they can know that this will get into a platform where it's secure and safe, as opposed to sitting in someone's Gmail, which, if they're working 3 days a week, which a lot of our nurses do, that it will still be available on their system 24 hours a day and 7 days a week, and they won't be sitting in someone's inbox or someone's phone, which is sent by SMS. So this really is a platform that is extrapolatable to other conditions in terms of model of care. So I hope I'd showed you something that have convinced you, at least to a degree, that if we make it really easy for the GP, where they can just enter fields with very little information, they're given clinical decision-making tools to help them make decisions, they would use it. Patients where if they have access to specialists and nurse on demand and they get a treatment plan that can follow very easily, they will use it. And as a result of them using it, they're less likely to come to hospital. And as a result, specialists may then start using it. So it's really more than just patient-centric, but almost healthcare in its entirety centric to deal with the efficiency of individuals, to incentivize them to the level where it improve their productivity, improve their management, to lead them towards this healthcare, which eventually will be much more cost effective. So just in terms of where we've come in the last 6 months, we have treated more than 150 patients on our system, for which these are patients that would not have had treatment otherwise. Even though it doesn't seem like a lot of patients in itself, as I mentioned, only about 800 patients were treated in one of the major tertiary hospitals within South Australia. So this is, in my mind, we've come quite a long way. So from that point of view, we're really hoping to deliver co-managed care to GPs in management of chronic diseases. We hope to develop a 360 registry, manage patients in real time, and improve health outcomes. These are some of the people that have saw value in our product, and we're working with some of the nation's best people: Hepatitis Australia, Liverpool University, Royal Lake Hospital, just to mention a few. So we've already won a few accolades, including the Don Walker Award in 2017, which was a big plus for us. We have met the Health Minister, Greg Hunt, recently, and he was, to our surprise, was extremely impressed and thought that this really should be the level of what My Health Record should have been, and really supporting us in terms of taking our initiative further. We've also met the Federal Minister of Indigenous Affairs, and he felt that this will really add to management of Indigenous patients who are obviously, unfortunately, a significant number of them are incarcerated, as well as those who are living in the community. So accessing to those patients via a digital solution would be a good potential option. Thank you for your attention.
So, do you have any questions, Maywood? I do hope so. Please.
Yes, thanks very much, Eddie, Paul Cooper. Just a little bit more about HealthyLink. So, is it a private initiative, or is this co-funded with government?
So this is a private initiative out of funding reasons, because our current environment with, for those of you who are in the medical field, grant funding is significantly challenging. And, we have less than 20% success rate at NHMRC. So really out of desperation, we had to have it funded privately to get it up and running. And we actually had more support from the business industry, surprisingly. So we actually had grants from the Northern Territory government in business initiative in terms of grant funding, which started us in this journey. And then now that we've got some data on the board and people actually see value in this, people are coming around. A lot of my colleagues, professors and the like, are very data driven. They say, oh, this is a great idea, but show me data. Unless you actually have built it, got patients on there to actually say that this works by way of a graft, they will never back you. And for that reason, we're now at the point that we've got our data, it works, it's real, it's tangible. We're now taking it to the next level.
Firstly, congratulations. I think it's really elegant solution. The biggest barrier I see with this platform is distribution, particularly trying to engage with GPs and specialists. What are you doing on that front?
That's a great question. So you saw that we've got more than 150 patients on that platform, and that is the result of one PhD student. And we had to go into very difficult environments, the prison services, which has its own security platforms and so forth. And people saw value in it, and and they made it work. And this is also not a auto login where you go to a website, log in your details, and away you go. This is them agreeing to be part of a trial. So despite all of those challenges, they're willing to participate because they see value in it. What you probably also may have heard of is the Primary Health Network. The Primary Health Network is an initiative by the Turnbull government and Greg Hunt to achieve goals exactly the same as ours, efficiency in our system, and trying to empower community GPs and to rationalise hospital resources. The way that they're doing that, though, for example, recently I was asked to review a document about abnormal liver enzyme tests, and that was an 8-pager that they asked me to write. And the Primary Health Network are then using the 8-page document for this one particular small condition, telling GPs, please read this before you send your patient to A, right? That's not going to work. So already there is going to be machineries there that is ready to go. And that's what we said to Greg Hunt, that you've got your people out there on Primary Health Network. We've got a solution. We want to work with you. We want to use this and your people on the ground to deliver healthcare in a different way. Give us a sector where you have problems with Hep C. Give us a sector where you have problems with diabetes, bowel cancer. With your people on the ground, we will make it work, and just get your GPs to use it. And GPs, if they find that they can get their patients in to see a specialist quicker, or if they feel that they don't need to send a patient and they can retain their patient just as good a care, they will adopt it. And we will take this to the next level where, with right funding, a lot of the information that you saw that Catherine was entering in could actually be pre-populated by the medical director software. It just takes additional smarts and support from the IT team. And if we make it easy enough that if all of that is seamless, then they will use it.
So I guess, so you're saying it doesn't have an interface at the minute with the medical patient, medical director or whatever. Yeah, and also what about my health record?
Perfect. So that's the same question Greg Hunt asked us as well. So my health record at the moment is a repository of information, but it doesn't have all the smarts related to how to utilize that information. So for example, all those clinical decision-making tools that allow for the GP to come to the decision of what treatment choices is made is beyond my health record. But what we don't have is the blood tests that allow for us to calculate that there is no advanced liver disease to make it safe for the GP to prescribe. We don't have the information by way this person don't have kidney failure, which can affect the treatment choices, whereas my health record potentially has. And the other aspect is also, as we all heard earlier this morning, very few are people adopting my health records because they don't see benefit to it. If we can actually say that if you have a chronic condition, you could actually have my health records to a level where you can engage your own specialist in real time so that they have all the information there to give you informed decisions, informed recommendations. I think more people will buy into my health records. It's a whole package that we're giving to everybody.
I'm slightly conscious of time, so I think we've got time for one more question.
Firstly, just a little bit of a statement, really. One of the things, I'm a consultant these days, I've worked in 6 or 7 different sectors. One of the things I'm not such annoyed at, but is we actually don't have a health system. We actually have a health network of things. And because when you overlay it with policy and delivery and services and pricing knowledge, it's actually very, very complex as well. One of the things we often do is we set expectations by calling it a system so the community and patients believe that it's there all the time to do everything they want to do. So I think we've got to actually change that debate and that statement if we want to bring a cultural change with a system like this, because I think the system is just, the way I see it, it's just fantastic. The question I have though, from a policy point of view, the question will be asked at some stage, what's the pricing model along the supply chain or the service chain? How do you solve that in that process? Because somebody's going to say, well, if you've got to take 5 minutes to do that, how do I get paid?
So that's a very good point. So at the moment, my salary is paid by the South Australian Health, for which it makes sense for me to see as little patient as possible, right? I get paid anyway, right? So what I am accountable as a head of unit is the waiting list, right? So if I had an ability to see a patient effectively with all the information I have without them stepping through the door, I get a pat on the back. What is challenging though, however, is resource delivery that because if I'm doing things too efficiently, I don't get paid by way of the department as much. So a lot of my nurses at the moment are on the phone, email and stuff, and there's no accountability in terms of their how much work they're putting in. So this platform allows that, so you can actually encompass the amount of activity you're seeing in terms of turnover, messages being put through by way of activity-based funding. So that allows us to do that. So I don't believe that this is a thing that is going to be revolutionising the private sector, but we all know that our premiums and health insurance are going up. And that's because of the public system is inundated. So by the way we resolve the difficulties within the public health system, we significantly will also improve the private health system to reduce our premiums and also allow for that to function much more freely.
Okay, so it will stay a little bit longer, I think, after we finish, so you're welcome to have a conversation with me. So first of all, thank you, Eddie. I'd like to give you a round of applause. And I'd like to invite Gavin Lunshaw, the Joint CEO, to come and close the meeting. Gav, close it this time rather than me back to me. Is that all right? Sure.
First of all, I never get sick of listening to you, Eddie. So absolutely fantastic, and I never get sick of listening to Rallis. So if you can put your hands together for Eddie and Rallis, I thought they were fantastic presentations. One from a personal patient perspective, as well as what's happening in the medical industry. So thank you very much. For us, it's really exciting at the moment. You know, we've got a chance to actually influence an industry. We've got a chance to change that industry. We've got a chance to bring learnings from utilities and financial services to health, and likewise take learnings back. And so, you know, putting the patient in the centre is not that different to what we've had to do for years, which is put the customer in the centre. Understanding that sometimes it's not just the patient, you've got to put the GP in the centre. And I think one of the big differences, if you look at the take-up, and I think there's 50 GPs who have elected to actually participate and treat patients without any real fanfare, without any marketing, shows the difference between what happens when you actually get people from the industry and people who are affected to help design the solution, as distinct from people who are like us, who are either technologists or bureaucrats alone to actually develop a solution. This solution was developed by the specialists. It was developed by GPs that actually know what it's out there to do, and as well as our guys bringing some of that, what does it mean to actually be a patient, and what does it mean to be the person affected. And that's how come we've got a solution that is out there fairly quickly. It's working. We're able to get trials, and we're able to actually listen to what people are saying and modify it and evolve it based on a platform that's pretty easy to maintain. So the reason I'm bringing that up for you is it's not unique to the health industry. That is something, and that approach is actually the approach we should be taking across all industries. It's, you know, we're at the stage now where we don't do 18-month projects to work out if they're actually going to deliver the benefits. We've got 3 months, get it out there, get feedback, and be able to modify and move forward with it without having to rebuild it. And so hopefully you got some value out of today. I know, as I said, I get energised every time I listen to it. I think we're so fortunate, a little bit humbled to be in the presence of people like you, as well as to actually be able to play in it. So thank you very much for attending. On behalf of Andrew, where's Andrew? Andrew, myself and all the DB people here, we're delighted to have you at this Insight series. Our next one, I think, is in August, which will be on robotics and AI. Exciting. I wonder if I get to learn how to use my drone properly. You're all welcome again. We'll send out invites to that. Everything you've seen today, you'll get an email with links to it, so you can actually access the information, as well as I'm sure we'll be on LinkedIn and YouTube and the normal website. So feel free to look us up. As I said, Eddie's going to stick around for a little while. If you've got any questions of any of us, ask us now or feel free to follow up. But we really appreciate you giving up your morning. Thank you very much, and thanks to Phil and the team who organised today, and especially to our two speakers. Thank you very much.